Hi, I'm Dr. Tess Castillo. This lecture will focus on common clinical presentation of the uveitis patient. At the end of this lecture, learners should be able to define uveitis, discuss the various classification schemes used for uveitis, particularly to be able to differentiate uveitic entities based on said classification schemes, and most importantly, be able to discuss the common signs and symptoms of uveitis. This lecture will be divided into three parts. Part 1 will cover items 1 and 2, definition and classification. We will then proceed to the next part, signs and symptoms of the uveitis patient. And finally, Part 3 will cover findings associated with chronic and recurrent episodes of inflammation and subsequently have a brief discussion on common complications of uveitis. Let's talk about definition and classification first. So, what is uveitis? Uveitis is a broad term used for any inflammation that involves the uveal tract, which is composed of the iris, the ciliary body, and choroid, as shown in the diagram here. Frequently, however, as you will later find out, there may be involvement of adjacent structures such as the sclera, cornea, vitreous, retina, and the optic nerve. Put simply, it can involve practically all internal eye structures. Before we proceed to what patients with uveitis present with, we should have an understanding of the various methods for classifying these conditions. Why do we need to classify uveitis? We classify since uveitis covers a vast number of variable conditions of differing etiologies and at times can even be associated with systemic conditions. Proper classification is therefore essential to arrive at the differential diagnosis which directs both diagnostic and therapeutic plans for our patients. It also allows for better prognostication of patients with uveitis. Uveitis is primarily classified according to the anatomical parts of the eye affected by the disease and its underlying etiology, whether infectious or non-infectious. They are also categorized based on the onset and course of the inflammation. It can be further classified based on whether or not the condition involves the eye alone or if there is systemic association. Uveitis can also be classified based on their clinical pathologic presentation, that is granulomatous versus non-granulomatous uveitis. All of these aid in the formulation of a reasonable differential diagnosis which determines both the diagnostic and therapeutic approach for patients. For purposes of this lecture, we will focus mainly on the anatomic classification and descriptors used as guide in the formulation of a differential diagnosis. The anatomic classification was developed by the Standardization of Uveitis Nomenclature, or SUN, working group. It is based on the primary site of inflammation. There are four categories under this classification: anterior, intermediate, posterior, and panuveitis. In anterior uveitis, the primary site of inflammation is the anterior chamber. Inflammation may involve the iris, ciliary body, or both the iris and ciliary body together. Intermediate uveitis is primarily characterized by the inflammation of the vitreous, the pars plana, and peripheral retinal complex. Included under this category is pars planitis, which refers to a subset of intermediate uveitis where no underlying etiology can be identified despite exhaustive performance of laboratory workup. Posterior uveitis involves the retina or choroid. Inflammation may be focal, multifocal, or diffuse. This category includes chorioretinitis, retinochoroiditis, retinitis, and neuroretinitis. Panuveitis refers to uveitis where the inflammation is present in all three locations: the anterior chamber, the vitreous, and the posterior segment. There is no predominant site for inflammation. This does not consider structural complications like macular edema or neovascularization. So, Patients who present with anterior segment signs of inflammation found to have concomitant macular edema are not classified to have panuveitis. These are still classified under anterior uveitis. This table summarizes the different categories under the anatomic classification of uveitis that was discussed earlier. Right. When classifying uveitis, we also look at each episode and at the entire course of the episode. For each episode, onset may be sudden, as seen in acute cases, or insidious, which is commonly associated with chronic cases. We also look at how long the episode lasts. If less than 3 months, it is classified as limited. If the disease course extends beyond 3 months, it is labeled as persistent. Additional descriptors on the course of disease are also used. Active uveitis are those entities where attacks are of sudden onset and limited duration. For a condition to be labeled recurrent, the eye should have been quiet for at least 3 months off all therapy. If patients relapse or go into activity every time you try to discontinue their therapy, that is, you cannot get your patient off meds for 3 months without the eye going into active inflammation, the disease is classified as chronic. To better understand this concept, let's look at the diagrammatic presentations of the timeline of the attacks. Shown here, okay, you have three diagrams. The blue arrowheads here indicate the periods when the eyes become inflamed, while the horizontal lines represent the periods of quiescence of medications. So if you look at the diagram corresponding to recurrent, you will notice that they have this horizontal line where the eye was quiescent before the two periods of attack. Okay. For chronic conditions, however, notice that there is absence of said periods of quiescence. Okay. So there is persistent inflammation. Etiologically, uveitis may be the result of infectious, non-infectious, or what they call masquerade causes as described by the International Uveitis Study Group or IUSG. More commonly encountered infectious causes are listed here. What we have here are some viral conditions such as herpes simplex, varicella zoster, and cytomegalovirus. Infectious causes also include syphilis, tuberculosis, and toxoplasmosis, as well as HIV. Masquerade conditions refer to diseases which resemble uveitis in their presentation but are secondary to non-inflammatory diseases such as lymphoma and other malignancies. Most non-infectious uveitis appears to be autoimmune or autoinflammatory. Non-infectious uveitis can be further divided into conditions with associated systemic disease and those without systemic association. Also listed here are some representative disease entities. Okay. Immune recovery uveitis, or IRU, is a phenomenon observed where patients with HIV develop uveitis shortly after initiating highly active antiretroviral therapy or HART. Idiopathic disease, on the other hand, refers to cases where no associated systemic disease or other precipitant is identified. The next part will cover common signs and symptoms found in uveitis patients. This part of the lecture will cover common signs and symptoms of uveitis. So what are these? This will depend on which segments of the eye are involved during episodes of inflammation. Therefore, we expect different symptoms and signs if a patient has anterior, intermediate, posterior, or panuveitis. Symptoms experienced by patients with anterior uveitis would depend on the course of the disease. Patients with acute episodes of anterior uveitis present with history of sudden onset of their symptoms and are often able to provide specific information as to when their symptoms actually started. They frequently present with classical triad of pain, redness, and photophobia. Patients complain of pain due to ciliary spasm and involvement of the ophthalmic division of the fifth cranial nerve. Redness, when present, is usually less compared to redness seen in patients with conjunctivitis. Photophobia refers to increased sensitivity to light. The sun or bright indoor light can be uncomfortable, even painful. Vision may or may not be affected. In chronic uveitis, disease onset is insidious, leading to a less precise history. Oftentimes, patients will be unable to provide specific information as to when their eye problem started. When symptomatic, these patients would often complain of presence of floaters or decreased vision. Anterior segment findings are best evaluated with the aid of a slit lamp biomicroscope. Redness is more confined to perilimbal area and results from congestion of deeper red vessels, giving it a dusky red color. As shown in the photo, the redness is radial in fashion. This type of redness can also be seen in keratitis and angle closure glaucoma. Keratic precipitates are depositions of inflammatory cells on the corneal endothelium. They are characterized and described based on their size, pigmentation, and distribution. Keratic precipitates present in various sizes which have their corresponding composition. Stellate KPs and medium-sized KPs are composed of neutrophils and lymphocytes and plasma cells. Fine KPs are more commonly found in Fuchs heterochromic uveitis and non-granulomatous uveitis. On the other hand, large mutton fat keratic precipitates are composed of macrophages and epithelioid cells. These type of keratic precipitates are associated with granulomatous type of uveitis. These photos show non-pigmented keratic precipitates of various sizes, while this photo shows an eye with pigmented keratic precipitates. So what then is the significance of pigmentation? The presence of pigmentation gives an indication of the chronicity of the inflammation. Lastly, describe your keratic precipitates based on their distribution. In most conditions, KPs aggregate in the inferior portion of the corneal endothelium, assuming a triangular configuration. This area is referred to as Arlt's triangle. In other conditions, as shown in the photo on the right, KPs may be diffusely distributed. Distribution of KPs also provide clues as to the possible etiology of uveitis. The presence of cells is the most important indicator for active inflammation. Inflammatory cells may be seen floating around in the anterior chamber or behind the lens. In cases when there is very high count of cells in the anterior chamber, this can be found to form a layer inferiorly, a finding we call hypopyon. Haziness of the anterior chamber, called flare, results from protein exudation in the anterior chamber due to damage to the blood-aqueous barrier that occurs in inflammation. In chronic cases of uveitis, flare may persist even in the absence of active inflammation. The standardized grading system used to document severity of inflammation or cells and flare will not be discussed in this lecture. Adhesions between the iris and the anterior surface of the lens, called posterior synechia, and between the peripheral iris and the cornea, called peripheral anterior synechia, are also common findings in anterior uveitis. Posterior synechia may be thick and broad-based, as shown in the left photo, or thin, as shown in this other photo. This, this type Posterior synechiae is more commonly seen in non-granulomatous type of uveitis. Iris nodules may present in a variety of conditions and are identified based on their location. Kepe nodules, found at the pupillary border as marked by the yellow arrows in the photo, may be present in both non-granulomatous and granulomatous types of uveitis. On the other hand, Busaka nodules, found within or on the iris stroma, marked here by the light blue arrows, are generally found in the granulomatous types of uveitis. Pupil changes in uveitis include meiosis, which occurs due to spasm of the ciliary muscle and contraction of the sphincter pupillae muscle. You can also find irregularly shaped pupils in patients with uveitis, which results from adhesions between the iris and lens, what we earlier referred to as posterior synechiae. In some patients, severe inflammation can lead to membrane formation at the pupillary area. Then always remember to check for history of use of dilator eye drops, as patients may have sought prior treatment before coming for consultation with you. In such instances, patients may also present to you with pharmacologically dilated pupils due to prior treatment. And lastly, always remember to check the patient for pupil reflexes, as this may be altered as well in uveitis patients. Intraocular pressure or IOP in uveitis patients may be low, normal, or high. Low IOP may occur due to reduced production of aqueous humor by the ciliary body. High IOP during acute inflammation is commonly seen in herpetic uveitis, Fuchs heterochromic iridocyclitis, and Posner-Schlossman syndrome, but may also occur in almost any form of uveitis over time. Notice here that it can also occur as a result of complication of steroid treatment, which is the mainstay of treatment for uveitis patients. Now, aside from differentiating acute from chronic anterior uveitis, you should also be familiar with differences between granulomatous and non-granulomatous anterior uveitis. Granulomatous uveitis may involve the posterior segment or involve all anatomic sites and present as panuveitis. Its etiology is often infectious, and it is generally insidious in onset and of chronic duration. Non-granulomatous uveitis, on the other hand, involves only the anterior chamber, is of non-infectious etiology, with acute onset and limited duration. Although limited in duration, note, however, that these conditions may have a tendency to recur. Inflammatory attacks in non-granulomatous uveitis are generally more explosive in nature, with patients complaining of eye redness, eye pain, and photophobia. Vision may be minimally affected in non-granulomatous uveitis. In granulomatous uveitis, redness, pain, and photophobia are usually minimal, but these group of patients more frequently complain of floaters and reduction in vision. As far as findings, they are differentiated based on the characteristics of keratic precipitates, iris nodules, and posterior synechiae. As shown in the left photo, granulomatous uveitis is associated with large mutton fat KPs, and both Busaka and Kepe nodules are usually present. Posterior synechiae is generally wide-based, as shown in the photo. The photo on the right shows a more inflamed eye with severe reaction, as evidenced by presence of a beginning membrane in the pupillary area. KPs are generally small to medium-sized, and when iris nodules are present, these are usually confined to the pupillary margins. So, only Kepe nodules are present in the non-granulomatous type, such that the presence of your Busaka nodules should point to a granulomatous type of uveitis. How about intermediate uveitis? Due to the presence of inflammatory cells floating in the vitreous, patients with intermediate uveitis typically complain of floaters. These patients also complain of diminished vision, sometimes due to the presence of vitreous haze, but often due to the presence of macular edema. Macular edema has been found to be the most common complication and cause of blurred vision in patients with intermediate uveitis. Patients may, however, be asymptomatic in mild cases. In intermediate uveitis, inflammation causes breakdown of the blood-ocular barrier leading to protein exudation into the vitreous, which can be seen as vitreous haze as presented in this photo. In the peripheral retina, there may be inflammatory aggregates which may form plaques in the inferior area, referred to as snowbanks, or they aggregate within the vitreous which appear like snowballs. Inflammatory cells may likewise envelop peripheral blood vessels, which may be seen as perivascular sheathing. Posterior uveitis patients generally complain of a variety of visual disturbances. Posterior uveitis may also be associated with floaters and the presence of image distortions such as metamorphopsia, macropsia, or micropsia. Patients also frequently complain of photopsia, a visual anomaly where flickering of lights are seen by patients. Visual field cuts or scotomas may also occur depending on the areas involved in the inflammation. Posterior uveitis findings include diffuse or local vitritis. Retinal vascular changes may also be seen. These present as vessel narrowing, increased vessel tortuosity, or presence of perivascular sheathing, similar to intermediate uveitis. Then in the retina, you may see the presence of infiltrates. Okay, they are creamy colored, usually oval in shape, as shown in this photo. The retina may also have areas of exudative retinal detachment. Inferiorly here, you see this is the detached retina. Okay. In this photo, there are focal areas of retinal detachment, giving the background this appearance. Also note the increased vessel tortuosity, probably due, most likely due to the retinal detachment. And you may be able to see nodules in the retina as well. Shown in this photo are Dehlen-Fuchs nodules, which may be present in granulomatous types of uveitis. These nodules represent proliferation of retinal pigment epithelial cells on Bruch's membrane appearing as small yellow-white spots similar to drusen. Granuloma represent collection of immune cells or granulation tissue, typically produced in response to infection, inflammation, or the presence of foreign substances. They may be associated with various etiologies. This photo shows a peripheral granuloma in a patient with toxocariasis, which presents as an amorphous whitish mass with tractional membrane, and retinal detachment may actually occur as the result of this traction membrane. So this is the traction membrane. They may also occur secondary to tuberculosis, as shown here, or fungal infections such as blastomycosis. Infiltrates may also be seen in the choroid. How do you know they're in the choroid? They are located, okay, underneath the blood vessels. And as earlier mentioned, the inflammatory process can also involve your optic nerve. Note the indistinct disc borders in both photos and the presence of hemorrhages in the right photo. Panuveitis patients may exhibit any of the symptoms previously discussed depending on the severity of inflammation in the involved anatomical areas. And of course, since there is no primary definite anatomic site for the inflammation in panuveitis, patients with panuveitis can present with signs of anterior, intermediate, and posterior uveitis. We come now to the third and final part of this lecture. In this part, we will tackle what findings will alert clinicians that patients had prior episodes of inflammation. We need to recognize this since it is not always the case that your patients will be aware that they have had prior episodes of inflammation. In the cornea, calcific band keratopathy may be present. Calcific band keratopathy is subepithelial deposition of calcium primarily in the form of hydroxyapatite in the epithelial basement membrane, Bowman's layer, and the anterior stroma of the cornea. They usually start at the temporal and nasal areas, as shown by these two arrows, but they may progress to cover the entire interpalpebral area of the cornea. Pupils may be obstructed by 360 degrees posterior synechia or a pupillary membrane, which results in pupillary block. When pupillary block happens, in patients where the ciliary body eventually recovers from the inflammatory process and regains the ability to produce aqueous then accumulates in the posterior chamber, which will push the iris forward. Okay, so the iris bows forward, a finding we call iris bombay. Other iris findings that may indicate prior inflammation may be the presence of iris atrophy. They may be diffuse or sectoral. Sectoral iris atrophy is very commonly found in patients whose underlying etiology for their inflammation is herpes. The iris may likewise lose its normal architecture, leading to moth-eaten appearance as shown in these photos. On the surface of the lens, you might also see what appears to be pigment deposition. Okay. These are actually remnants of posterior synechia that had been broken with the use of pharmacologic dilating agents. In the retina, destruction of retinal pigment epithelium and Bruch's membrane can result in the formation of chorioretinal atrophic patches, sometimes with sclera peeping through. There is usually proliferation of RPE at the edges, leading to this appearance of chorioretinal scars. These scars can cause permanent scotomas and may actually be bothersome to patients depending on where these are located. Lastly, let's briefly go through some of the more frequently encountered complications in patients with uveitis. All forms of uveitis may develop sight-threatening complications over time. Cataracts can result from repeated bouts of inflammation or as a consequence of chronic steroid use. Performing cataract surgery in these patients can be very challenging and would require special precautions. Patients with chronic uveitis may develop glaucoma of varying mechanisms. Open-angle glaucoma may result from blockage of the trabecular meshwork by inflammatory cells and protein, inflammation of the trabecular meshwork, or as a complication of prolonged steroid use. As I also mentioned earlier, pupillary block secondary to seclusio or occlusio pupillae can lead to development of secondary angle closure glaucoma. Cystoid macular edema occurs when inflammatory mediators reach the macula. CME can result from inflammation in any segment, that is, patients with anterior, intermediate, or posterior uveitis may present with CME. The retina does not have to be the primary site of inflammation for CME to develop. This remains to be the most common cause of visual loss in uveitis patients. And lastly, hypotony. Acute inflammation of the ciliary body leads to transient hyposecretion of aqueous. Chronic ciliary damage from repeated episodes of inflammation leads to permanent hyposecretion of aqueous which leaves the eye in a persistent hypotonic state. This leads to a shrunken, atrophic, non-functional eye we refer to as phthisis bulbi. Phthisis bulbi represents an ocular end-stage disease characterized by shrinkage and disorganization of the eye. So we've covered the following in this lecture. We discussed the general definition for uveitis. We also talked about the various classification schemes used for classifying patients with uveitis, and we also discussed the common signs and symptoms, which was the meat of this lecture, common signs and symptoms associated with the condition. Also touched on signs that may alert you as a clinician to the presence or history of prior inflammation when the patient comes to you. And lastly, we also covered common complications associated with uveitis. Let me end this lecture by giving some key points to remember. Uveitis is caused by disorders of diverse etiologies, including a wide spectrum of infectious and non-infectious causes. It's important to determine under which category your patients fall under, as this will determine not only the diagnostic plan, but also the therapeutic plan for your patients. On classification, classification serves as an essential tool for the formulation of reasonable differential diagnosis, which determines the formulation of a rational diagnostic and therapeutic plan for uveitis patients. The major classification scheme used for uveitis is the anatomic classification, which is based on the primary anatomic site involved in the inflammation. Remember, though, that your structural complications like macular edema or neovascularization are not considered in the determination of anatomic classification of uveitis. And lastly, always remember that inflammation involving any region of the eye can lead to vision-threatening complications. So that's the end of this lecture. Here are my references. Thank you and stay safe.